Today we are discussing about pediatric rash. Okay, before that, um, I'm gonna tell like what are the pediatric rash that's are most important. Okay, so pediatric rash, we have different types like viral, bacterial, right? Fungal, then parasitic. So we have different types. So we have viral, measles, rubella, roseola infantum, erythema infectiosum, varicella, hand-foot-mouth disease, herpes simplex, and molluscum contagiosum. These are the viral. I'll share this. Okay. Um, I have a small like note, so I'll share the topics. Then what are the bacterial? The one of important ones are impetigo, scarlet fever. Then we have like the mainly these two are the most important. Then other than this, we have meningococcal rash and cellulitis. So those are the common. But for the small children, for the pediatric population, the main two are impetigo and scarlet fever. Okay. Then parasitic, we have scabies and pediculosis, right? So these two also very important. Other than that, we should know about Kawasaki disease, right? Because usually they are giving this Kawasaki and scarlet fever like to like confuse these two. So we will discuss these things, okay? But I'm not sure we can discuss everything, but let's try to do as much as we can. Okay. So first we should discuss about impetigo, right? Impetigo, let's discuss. So what is impetigo? What is it, doctor? Impetigo? We call it school source, right? We call it school source as well. Why? It's an infection of the skin caused by bacteria. Okay, and this is most often called school source because it is mainly common among the school children. Okay, so here, um, thing, if for impetigo, you have to follow this one. Okay, you have to follow therapeutic guideline. Okay, and RCH as well. But in RCH, there has nothing mainly important points have added. So please follow the therapeutic guideline for impetigo. Okay. So in here, impetigo, we have two types, non-bullous and bullous impetigo. Okay, so what are the two types, non-bullous and bullous impetigo? So, and before that, I'll show how impetigo is present. Okay, not this one. Okay, first discuss this one, then we will see the pictures. So impetigo is characteristic as limited up to two source or extensive more than two source and can either be non-bullous or bullous. So non-bullous mean what? Presents as round, pus-filled or golden blisters which is eventually form a yellow to thick crust. Okay, so we call this crust is how? Honey appearance, right? So what we call this crust? Honey crust, right? Okay, I'll show the good picture. Here you can see it's like a honey colored crust, right? Here you can see. Mhm. You can see this is okay. So please remember this picture because in June exam they have asked from this impetigo part. Okay, so please remember this one. Yeah, honey crusted. Good doctor. Yeah. Then. Mhm. This is non-bullous. Okay, non-bullous mean you have to remember here round pus-filled or golden blisters can be pus-filled and it can be golden blisters as well, which eventually form a yellow to thick crust. Sores may be itchy or irritating but not painful. So it is not painful but it can be itchy. It can be discomforting, right? Then non-bullous impetigo can be caused by Streptococcus pyogenes. Okay, it's a group A Streptococcus or Staphylococcus aureus or both. So these are the causative organisms, Streptococcus pyogenes or Streptococcus, so Staphylococcus aureus or both can cause. Then what are the bullous one? Here bullous one is here okay another picture of non-bullous. This is the pus filled one and here you can see the yellow color crust as well. Bullous one present as large floppy blisters rapidly developing into the erythematous shallow erosions. Systemic symptoms of malaise, fever are more likely than with non-bullous symptoms. So the bullous one is kind of severe one, not like non-bullous because it has some systemic features as well. So you should know how to differentiate bullous and non-bullous. So these are the features. And this bullous one, the severe one, mainly caused by Staphylococcus aureus. Okay, remember. Okay, then here bullous one, it has the erythematous rash right here. You can see the large erythema after the blisters. Okay, then here, yeah, fluffy blisters rapidly developing into erythematous shallow erosions. Here, they are erosions. Yeah. Then they have mentioned patients with impetigo do not require an initial skin swab before starting empirical therapy unless the diagnosis is uncertain or impetigo is recurrent. So if it is the first episode, and we are highly suspicious of impetigo, so we don't need to do the skin swab. Even bacterial we don't need to do, but if this is uncertain, no, we have some, we have like suspicious about the is impetigo or not, then we can do. And if there's a recurrent impetigo, we have to do the skin swab. Okay, so remember the indications for the swab. And so who
This
can
guy is
give
guy. Welcome.
doctors? My God, every day, Dr. Joseph, can you mute your mic? Please keep your mic muted. Every day your mic is on. Yeah. Okay. So, tell me what is the treatment of impetigo? Who can tell me? What is the first line treatment? Type in the chat. It's a very high part. You should know. Type in the chat. Mm-hmm. Mupirocin, right? Mupirocin. So this is the first line treatment. Okay, let's discuss about the treatment and it has some differentiation as well. Yeah. No need to read this one. Yeah. It's a management of impetigo. Treatment of impetigo supposed skin healing and prevent the development of more serious complications like sepsis, bone joint infections, post-streptococcal complications, including acute rheumatic fever. Then management of impetigo involve all of following: anti-infective therapy, that means empirical therapy for the with limited non-bullous impetigo, and empirical therapy for extensive recurrent bullous impetigo. Okay, you should know what is the indications for bullous one, so non-bullous one, and the extensive recurrent or bullous impetigo, because bullous one is what's a kind of severe one, right? Yeah. Then yeah. Okay, here. So, empirical therapy for patient with limited non-bullous impetigo is a less severe one. Okay, less severe one is this. Minute. Okay, this is the less severe one. So here, for patient with non-recurrent, limited, non-bullous impetigo up to 2 source who are not at high risk of acute rheumatic fever, okay, who are not risk at acute rheumatic fever, we can give what is in the chat. Yeah, doctor here. Less severe one is non-bullous. Okay, here this one less severe non-bullous. The bullous one is the severe one. It has large fluffy blisters and rapidly it become to the large erosive erythematous lesions, ulcers. Okay, and it has some systemic features like fever, malaise. You can see, but not with the non-bullous one. Okay. And this is new part. Okay, this is a new part. They have add something with risk factors with rheumatic fevers in patient with imperial. Let's little bit read about it. Okay. Assessment of patients' risk of acute rheumatic fever is an important consideration when treating impetigo. So, what is it? An individual is at risk of developing acute rheumatic fever if they are younger than 40 and any of following. Aboriginal or Torres Strait Islander, person living in a rural or remote area, Aboriginal or Torres Strait Islander, or this like Maori or Pacific person, living in household affected by overcrowding or experiencing socioeconomic disadvantages, a person with history of acute rheumatic fever or rheumatic heart disease, or a part of family or household which a member has recently history of acute rheumatic fever. Okay. Then for individuals younger than 40, but particularly between 5 to 20, other risk factors that can cause sorry that could put them at higher risk of developing acute rheumatic fever include living in a household affected by overcrowding, experiencing socioeconomic disadvantage, current or prior residence in or frequent recent travel, Australian setting with high rates of acute rheumatic fever, and current or prior residence in or frequent or recent travel to international setting with higher rates of rheumatic fever. So, assessing risk of acute rheumatic fever should include clinician knowledge of the patient, understanding the community epidemiology. So, we have to determine the risk of acute rheumatic fever with impetigo. This is a new part, doctor. Yeah. Then let's, what is they have mentioned? Yeah, acute rheumatic fever is more likely to occur following recurrent streptococcal infection, including impetigo. So, treat impetigo in all patients at high risk of rheumatic fever with empirical therapy for patient with extensive recurrent or bullous impetigo. Okay, if a patient is a high risk one to get acute rheumatic fever. In those patients, in those children, we have to treat like it's a high severe, like bullous impetigo treatment. Okay, we have to treat like that. That's what they are mentioning in here. Yeah, then okay, this is for empirical therapy for patient with limited non-bullous one. So non-bullous one, what it can have the pustular and honey crusted lesions, right? And there's no systemic features. This is a less severe one. So how we should treat and these patients, like usually this non-bullous impetigo up to 2 souls, okay, who are not at high risk of acute rheumatic fever. So we can use myopericin. We can use myopericin 2% ointment or cream topically to crusted area 8 hourly for 5 days. So remember this. Or the second line, the second option, hydrogen peroxide 1% cream topically to crusted area 8 hourly for 5 days. So this is for non-severe impetigo, okay? Then patient with limited non-bullous impetigo who are risk at acute rheumatic fever use empirical treatment with that the treatment use the bullous impetigo treatment, okay? Then empirical treatment with extensive recurrent or bullous impetigo. And the patient, and one more thing we should know, and the patient who is having the non-bullous impetigo with high risk of acute rheumatic factor, acute rheumatic fever also should treat with this management. So remember, for this one, bullous impetigo treatment, we use in high risk patient with non-bullous impetigo as well. Okay. Then here, narrow spectrum antibiotics active against Streptococcus pyogenes or group A Streptococcus and Staphylococcus aureus like dicloxacin, flucloxacin are recommended as first line oral therapy. They are oral, okay, because it is extensive, it is bullous, right? And patient is having high risk factors, so we have to give oral therapy. Yeah. Then what is this is based on, yeah. And this is based on data that benzathine, benzyl penicillin, and trimethoprim sulfonylurea are equally effective for the treatment of impetigo. I will discuss, okay, here they have added this one as well. So let's discuss here. For patient with extensive, that means more than 2 sores, or recurrent or bullous impetigo, or what is the other indication? What is the next indication for this treatment? Hurry up and type in the chat. What is the other indication? What is the other indication, doctor? Yes. Patients with impetigo and having high risk for acute rheumatic fever. Yeah. So you should know what are these high risk aboriginial. Okay, these are the high risk part. Yeah. Good. I wanted to check you that you understood or not. Okay, so what is the treatment? We have dicloxacillin 500 milligram orally 6 hourly for 5 days. Stop therapy after 3 days if infection has resolved. Or we can give flucloxacillin 500 milligram. Who are the Aborigines? So Aborigines people are who are the First Nation people. Okay, who are the First Nation people in Australia? Yeah, national people. Okay, so it's a flucloxacillin 500 or decloxacillin 500 we have to give. Then, if the patient is having, okay, cephalexin enable less frequent dosing is often preferred to declox or flucloxa in children because liquid formulation is better tolerated. Hmm? And trimethoprim sulfamethoxazole is another alternative with these features. Okay, if there is a penicillin hypersensitivity, we can use cephalexin or trimethoprim sulfamethoxazole. Oh, yeah, the same drug. dosage is different here. Then consider single dose of treatment with intramuscular benzathine benzyl penicillin if preferred by patient or carer. Okay, if a mom come in with his baby with impetigo, like bullous impetigo, and mom is requesting a single dose of treatment for that. In that case, we can give intramuscular benzathine benzyl penicillin as a single dose. Okay, so we can give this by preferred by patients or the carer. Then, if a patient develop impetigo while receiving benzathine benzyl penicillin, uh, then penicillin for prevention of recurrent acute. Yeah, we have to take the actions for the rheumatic fever prevention. And yeah, that's it. And what is for patient who have non-severe? Okay, we just discussed these things. Yeah. Then what else they have mentioned in here? Mm-hmm. So, what is the school exclusion criteria for Impetigo? Tell me. Tell me what is the school exclusion criteria for Impetigo? 24 hours from what doctor? It's a 24 hours of treatment, right? 25 hours of antibiotic treatment. Yeah. Yeah, doctor. So when we are studying for these pediatric rashes, you should know school exclusion criteria is a very important for AMC. Okay, you should know the school exclusion criteria. And in Impetigo, it's like 24 hours from the uh, onset of treatment. Here your child can go back to childcare, kindergarten, or school after 24 hours of treatment and when the sores are completely covered with dressing. Okay, so 24 hours of treatment, our child can go to school, but the mother should make sure to cover all the crusted lesions with a dress, right? Do the mother has to do the dressing before going to school, right? So remember this. You can give it a rate. This is from RCH. They have clearly mentioned like how to we use hygienic, how to what are the hygienic measures that we can use. Okay, like that. Yeah. Mm-hmm. Okay, here you can see. Yeah, that's all for Impetigo. So let's do some question. Minute. I'll show some questions. Okay, we got six questions. Okay, so here, a 4-year-old boy present to the GP clinic with his mother and a mother with a 2-day history of painless rash on his face. He is otherwise well and he has no significant medical history and take no regular medications. His immunizations are up to date. On examination, he appears well with vital signs within normal limits. The rash is slightly tender to touch and consistent honey colored crust over small pustules. Here you can see. So, which one of the following is most appropriate treatment? So, what's the treatment? Quickly type in the chat because we don't have much time. We have a lot to cover. So, tell me. Type your answers in the chat. Type your answers. Okay, let's check your answer. And what is the type of this? Is bullous or non-bullous? Tell me quickly. Non-bullous, right? Okay, good. Mm-hmm. Good. Okay, non-bullous impetigo, honey-colored crust. Topical mupirocin is the first line. Yeah, I'm not taking much time. 25 years, non-indigenous man present to the urban general clinic for 5 days. History of itchy, painful blisters on his leg. The lesion began as red raised area that developed into fluid-filled blisters, which subsequently ruptured. He has no significant medical history and take no regular medications. On examination, he appears well with vital signs within normal limits. There are two small vesicular lesions and with honey color crusted on his leg. So, what do you think? What is this, doctor? Type your answers.
Okay, that again. Aga to buy me mineral.
Dr. Joseph, can you please mute your mic because it's very hard to go and mute you every time. Please be respectful. Thank you so much. Okay, so what do you think? Okay, let's check your answer. Good. What is this? Patient present with classic features of non-bullous impetigo, superficial bacterial skin infection typically caused by Staphylococcus aureus or Streptococcus pyogenes. And yeah, the same thing. No need to. And localized impetigo less than 3 source in immunocompetent patient provide the target antimicrobial therapy with the minimal systemic absorption and excellent efficacy again. The what is in the chat? Okay. 45-year man present to the GP clinic with painful leg ulcers that have been present for 2 weeks. He works as a laborer, recently sustained minor injury to his leg and construction site, but did not seek medical assistance. He has significant medical history and take no regular medications. He lives alone in temporary accommodation with limited access to washing facilities after recent nasty separation. Nasty separation. On examination, he appears well with vital signs within normal limits. There are multiple round ulcers on both lower legs with thick adherent gray brown crusted and surrounding erythema. The ulcers are 1 to 2 centimeter in diameter with punched out edge and that extended into dermis. So what is this? What do you think, doctors? Some doctors are going in topical meals. Mupitsin. Good. What is this? Calcium. Let's check. Yeah, okay. This is a presentation of ecthyma. I'll show you. This is not paid rash, okay? The type of impurity. It's like another like severe case, like it's going into deeper down the skin. Here, a deeper variant of impetigo, lower limb, buttocks, legs, and thigh. Here, appearance is small bulla or pustula on erythematous base and crusted, often indurated, tender plaque erythematous ring. Here, the punched out ring, right? Here, that's what in the question they have mentioned. Yeah, okay. So go back to question. Bacterial infection of the skin that extend into the dermis. So impetigo that go deep down in the dermis. It's typically caused by Streptococcus pyogenes or Staphylococcus aureus. The characteristic appearance include ulcer with punch out edge and thick adherent crust, typically over the lower lip. Risk factors include poor hygiene, minor trauma, and poor living conditions, all of which are present in this case. Then, oral flucloxacillin is most appropriate treatment as systemic antibiotic are required due to the depth of infection. The duration of treatment is 1 week to 2 weeks. Unlike superficial impetigo, topical antibiotic alone is not insufficient. So, other than impetigo, you should know about these ecthyma because in emergency they have mentioned about ecthyma means superficial. In impetigo, it's a superficial infection, and in ecthyma, it can invade to the dermis. So, in that case, the topical antibiotic cream is not enough. So, in that case, we have to give oral penicillin, right? Fluclox or declox, that is sensitive for streptococcus and staphylococcus aureus, right? Yeah. Please remember. Then the next one is 8-year-old boy present to the GP clinic with his mother due to two itchy areas on back of his leg that developed over the past 3 days. He has a history of rash to penicillin. His younger sister had similar presentation 1 week ago. He has no other significant medical history and take no regular medications. On examination, he appears well with vital signs normal limits. Two discrete areas of honey colored crusted erosions are visible on the posterior aspect of his left knee and right calf. Which one of the following is appropriate treatment? So type in the chat. Mm-hmm. Your answer is E. Let's check. Okay, so what is the next question? Yeah. Okay, we'll do this one and go back. 28-year-old Aboriginal woman present to the GP clinic with her two children, aged 3 and 5 years. She reports that both children have recurrent skin infections and frequent colds over the past year. She mentioned feeling stressed and overwhelmed, struggling to find that quiet space for the children to do their homework. On further questioning, she revealed that she lives in a three-bedroom house with 11 of other family members, including her parents, siblings, and their children. On examination, both children appear generally well, with vital signs within normal limits. The 3-year-old has several small crusted lesions on their arms, legs, consistent with impetigo. Which one of the following is most likely to be contributing this family's health issue? General question. What about other doctors? Mhm. We got A's and C's. What do you think? Do you remember we just read about this overcrowding houses, right? Do you remember we just read about that? Okay, so let's discuss something else. Before that, I have to stop the recording.